Good morning all. Welcome back to today's class. So in previous classes we have learned regarding cyanotic and acyanotic heart diseases. In this class we will be dealing with the other congenital heart lesions in pregnancy. First one is coarctation of aorta. So the maternal risk are hypertension, aortic dissection, bacterial endocarditis and cerebral hemorrhage due to ruptured intracranial aneurysms. So of the ruptured intracranial aneurysms that will leads to hypertension, aortic dissections, bacterial endocarditis and cerebral hemorrhage. Maternal mortality is high, that is 3 to 9%. Then fetal loss is also increased to 25%. Then surgical correction should be done prior to pregnancy. Termination of pregnancy should be seriously considered. Elective cesarean section is preferred to minimize the dissection associated with labor. So second one is primary pulmonary hypertension. It is characterized by increased thickening of muscular layer of the pulmonary arterioles. The cause remain unknown. Maternal mortality is about 50%. Majority will die, that is 75% in postpartum period. The fetal outlook is also gloomy. Termination of pregnancy is indicated. Bed rest should be imposed from 20th week of pregnancy. Then anticoagulants, that is heparin, is administered. Sildenafil is used as a potent vasodilator as it will increase the endogenous nitric oxide. Oral nifedipine or IV prostacyclin helps pulmonary vasodilatation. Epidural morphine gives effective analgesia without any hemodynamic changes. Women with pulmonary hypertension and right ventricular dysfunctions are strongly discouraged to become pregnant. Next we will see Marfan syndrome. So this is coarctation of aorta, that is ductus arteriosus, you can see postductal and periductal. This is Marfan syndrome. So it is an autosomal dominant condition. There is 50% chance of transmission to the offspring. Dilatation of aorta more than 40 mm as evidenced from echocardiography is a contraindication of pregnancy. Beta blocking drugs should be used to maintain resting heart rate around 70 beats per minute. Hypertension should be avoided to prevent the aortic dissection. Vaginal delivery is desirable with the shortening of second stage. When the aortic root diameter measures more than 4 cm, mortality increases to 25%. Women with aortic diameter more than 5.5 cm should have graft and valve replacement before the pregnancy. Then prosthetic valves. What are prosthetic valves? These are used for the significant valvular disease. We will use prosthetic valves. So mechanical valves are durable, but that will be requiring some of the anticoagulations. Then the risk of thromboembolism is high with low molecular weight heparin rather than the warfarins. Then bioprosthetic valves, that is porcine, are superior to mechanical valves. Next we will move on to cardiomyopathies. So cardiomyopathies are divided into two, that is peripartum cardiomyopathy and myocardial infarctions. What do you mean by peripartum cardiomyopathy? It is important diagnostic criteria are cardiac failure within last months of pregnancy or within 5 months postpartum, no determinable cause for failure, absence of previous heart diseases, left ventricular dysfunction as evidenced on echocardiography, ejection fraction less than 45% and left ventricular end diastolic dimension more than 2.7 cm square. Peripartum cardiomyopathy is a diagnosis of exclusion. The patients are usually multiparous and young, that is 20 to 35 years. They complain of weakness, shortness of breath, cough, nocturnal dyspnea and palpitations. Examination reveals tachycardia, arrhythmias, peripheral edema and pulmonary rates. Pregnancy is poorly tolerated in women with dilated cardiomyopathy. The treatment is bed rest, digoxin, diuretics, preload reduction, hydralazine or ACE inhibitors, that is postpartum afterload reductions, beta blockers and anticoagulant therapies. Vaginal delivery is preferred. Epidural anesthesia is ideal. There is no contraindication of breastfeeding. Mortality is high, that is 20 to 50% due to CCF, arrhythmias or thromboembolisms, and it may recur in subsequent pregnancies. Then we will see the myocardial infarctions. It is rare in pregnancy. Management is mostly as in non-pregnant state. Coronary angioplasty, stenting and thrombolytic therapy have been done in pregnancy when indicated. Supine positions and hypotensions should be avoided during the pregnancy. How will we manage the labor? So manage it as with standard cardiac care. Elective delivery within 2 weeks of infarction should be avoided. Regional analgesia for pain in labor and beta blockers for tachycardia may be used. Maternal pushing is avoided and second stage is shortened by forceps or vacuum. Syndocinon should be used in the third stage management as ergometry may cause coronary artery spasm. Diuretics to be used postpartum. Percutaneous transluminal coronary angioplasty can be done successfully around 36 weeks of pregnancy if needed. Conclusion. Some of the normal cardiovascular changes of pregnancy also may be observed in heart disease. Therefore, they should be carefully considered when the cardiac status of the pregnant woman is evaluated and the healthy woman has the ability to adapt it to the stresses that the pregnancy will reimburse or the cardiovascular system. However, the woman with heart disease may not have the cardiac reserve to adjust these new demands. Hope you understood. So we will see some of the nursing diagnosis in cardiovascular diseases. First one is knowledge deficit related to effects of cardiac disease on pregnancy. Then activity intolerance related to increased metabolic needs of pregnancy in presence of impaired cardiac function. Anxiety related to fears of uncertainty of pregnancy outcome. Hope you understood. So cardiovascular diseases in pregnancy is finished. If you have any doubts, please ask in comments. Thank you for watching my video. Please subscribe and share to your friends.